So thank you, Surjo, and it's always a pleasure to speak in this session because again we need to discuss our problems and we need to show what goes wrong in our surgery so that it doesn't happen or we minimize it in future. And definitely, when it comes to surgical nightmares, it has given all of us sleepless nights, to us as the doctors, definitely to the patients and his relatives or her relatives. And I would like to share a case of squint, and this was a 29-year-old unmarried female professional who came to me, and both for distance and near, the squint evaluation showed about 35 prism diopters of exotropia. He was referred by a colleague of mine, and she was referred by a colleague of mine, and this is the pre-operative. After everything went wrong, I asked her for pre-op pictures of her, and she sent me a soft copy of it. Now, what you notice here, just keep a close look on the picture, and we'll discuss later on what went wrong. Apart from the exotropia, there is one feature which is quite marked in this picture. And then again, we did a repeat assessment and squint evaluation. We were quite sure it was around 35 to 40 prism diopters for both distance and near. So what we did, we planned a 2 muscle surgery, and we decided to do a large lateral rectus recession 9 millimeter. This is again a point which may have gone wrong. Because normally for about 30 prism diopters, we do lateral rectus recession 7. So for 35 to 40, we are doing 4 extra, which is scientifically speaking about 10 prism diopters extra. And things started going wrong right from intubation. Our anesthetist kept on trying for about 35-40 minutes and could not intubate. And that patient, though being an adult patient, was so apprehensive, she didn't want a surgery under local anesthesia. She wanted it under general anesthesia. And finally, intubation failed. Then we took the patient on propofol and tried to do a very fast lateral rectus recession surgery. Surgery, anyways, just to demonstrate how we do it. The muscle was hooked and interlocking sutures were given. Muscle disc inserted and reinserted 9 millimeter behind the insertion of the lateral rectus. So till this time, apart from the failed intubation, it went off well. So what happened? First day, we are getting very slight overcorrection, flick esotropia. Things are fine till now, and when she came on glass appointment, that is about a month from the surgery, the esotropia increased 16 to 18 prism diopters. So what we did, we added prisms to her spectacles so that it gives some cosmetic, better cosmetic look. And as months passed by, the esotropia kept on increasing. It is now we have a situation in which pre-operatively the patient was 35 to 40 prisms of exo, and with both eyes lateral rectus recession of 9 millimeter, we have created a correction of 35 plus 30, 65 prism diopters. So what now? Since almost 2-3 more months had passed on from the glass appointment, we decided, and there was a gross overcorrection, we decided to take up her for surgery again. And this time we just decided to do one eye medial rectus recession 7 millimeter. And why didn't we touch the operated muscles? Because again, we know that there is a difficult intubation and the patient is very apprehensive. That will take more of surgical time. So we decided to tackle the third muscle. And post-operatively, though the situation was not as good, but we could manage with a very small esotropia in the patient. Most importantly, till this surgery, we were not taking one factor into consideration. And if you, as I asked you in the first picture, if you notice, the eyeball is small. And in small eyeballs, if we go by go as a routine case, and we plan as a routine case, there are very high chances that we will land up with overcorrection. In small eyeballs, we have to titrate our recessions to on the lesser side, so that because the effect of recession or resection is much more. So that was the learning experience what we had in this case, and fortunately after this I didn't have such a large overcorrection in any of my cases. So thank you very much.